All right. First up, I would like to introduce Dr. Raza, who is a transfusion medicine specialist at Sunnybrook Health Sciences Center, and also a medical officer with Canadian Blood Services, and also practices internal medicine at Unity Health Toronto. As a physician researcher, his work focuses on transfusion medicine, hematology, and the application of data science to healthcare. Through his clinical practice and research, Dr. Raza is committed to advancing evidence-based approaches that improve the safety, quality, and effectiveness of healthcare delivery. And following that, we're going to hear from Dr. Mack, who is a hematologist with expertise in therapeutic apheresis and transfusion medicine. He completed his training in internal medicine and hematology at McGill University, followed by a joint fellowship in transfusion medicine at Harvard Medical School. He is the medical director of the Apheresis service at McGill University Health Center, where he supervises the red cell exchange program and is involved in developing the transfusion medicine program, apheresis service, and benign hematology. So we have many experts here today, and we heard a little bit about transfusions this morning, but now we're going to learn more about apheresis, so I'm very excited. I'm going to turn it first to Dr. Raza.
I think this mic might work.
All right.
Okay. Okay. So I'll start by saying that I think somebody else was originally slotted for this talk on apheresis, and I think they couldn't make it, so I was slotted to give this talk instead. So actually my talk is not specifically about apheresis, but it's about sort of evidence-based practice in sickle cell disease and a study that we completed recently on looking at practice in Ontario. So I think it'll still be relevant, it's just not apheresis specific. And the session is titled Treat Patients, Not Numbers, Threshold-Based Transfusion in Sickle Cell Disease. So I have no disclosures except to say that although I work at a hospital and CBS, I'm not here to represent CBS. And I say that because I want to be able to speak my mind on some things I think are important about sickle. And I'll start by saying that although Canada has universal health care on paper, access we know to specialized, high quality care is not uniform. Like if you happen to be in the wrong postal code, or if you have a rare disease, or if you have certain types of disabilities, for example, you're not going to get like the top quality healthcare that people downtown Toronto might get. And we know from, I was a hematologist and I treated these patients and I still do general medicine. I know from speaking to a lot of people that the care is just not the same outside, even like a commuting zone. Like if you can't get to the hospital within 40 minutes, like your healthcare is very different. So that's the question that motivated us to ask this research question, which is, does the hospital where a sickle cell disease patient presents with an issue, does that influence how often they are transfused red cells? And essentially, like, do they get a transfusion, and how do transfusions differ at different types of hospitals? In hospitals, we were particularly interested in looking at teaching versus non-teaching. So teaching hospitals are these university-affiliated hospitals. They have lots of residents. They have lots of educational rounds. They're constantly getting practice updates. Community hospitals, I think, have equally good, sometimes better physicians, but they may not be getting the same guideline uptake. Like if a guideline comes out, it may take like months, sometimes years for that to really percolate down. And they tend to have also less like sickle cell expertise. They may not have a specialist who just cares about sickle. Whereas like downtown, like Toronto General has like 50 hematologists and there are 4 who just do sickle. At a smaller hospital, you have a hematologist who, whatever their interest happens to be, that's who's getting the like really state-of-the-art care. And how they're transfused red cells, we know that sickle patients are supposed to get red cells differently than any other patient population. So for every other patient population, we use thresholds. We say like if you're less than 70 hemoglobin or less than 80 hemoglobin, boom, like you're going to get a transfusion. Sickle is very different. In sickle patients, the recommendations from Canada and the US is basically don't use thresholds. Don't use a number to treat these patients. Individualize every single red cell that they're going to get, both because transfusions can be life-saving, and there's this tension between transfusions being life-saving and life-threatening. Like in the wrong patient, if you reflexively, like if you see 69 hemoglobin and your spinal reflex is you'll do a lot of harm. So that's why it's really important to get transfusion right. And so explicitly people say don't treat the numbers in these patients. And I'll show you whether or not that happens. Before I do that, there's a big data set in Ontario called Gemini. They recently got like $200 million from the government to expand nationally. So this will be relevant if you're not in Ontario. But basically, if you think of a hospital admission of like somebody who's 59 years old, coming in with sickle cell disease, past medical history, get a certain procedure, get exchange transfusion, go to ICU, then eventually get discharged. Like Gemini captures all of these variables I've highlighted in color. And that's just to say that essentially it's an electronic healthcare record for admitted patients that's trying to capture the whole patient journey and trying to reconstruct it in data. And this is really important because I think emotional appeals are great, but they just don't work on people sometimes for policy, to make arguments, to show the impact of bad care versus good care. So Gemini is the data set we used for our research. And we looked at care from 2016 to 2020. Actually, it's 2024 now, not 2022. We had adult patients in this analysis. Any patient with sickle cell disease who went to a hospital in the Gemini network, which is 29 hospitals in Ontario. It included some large tertiary centers. It included some smaller community centers. And we looked at transfusion and lab results for hemoglobin. And we looked at certain subgroups that I'll talk about later, but we looked at patients specifically at teaching versus non-teaching hospitals to see how care might differ. And we did. I'll say that we actually didn't capture like clinical notes, which I know patient perspectives are really important, so you'll just see high-level data here. Our primary analysis had 4,086 admissions with sickle cell disease across about 3,000 sickle cell patients. So that's like small numbers in my big data world, but it's like a really big sickle cohort in like the sickle world. So I think in Canada, this might be the largest study of hospitalized patients. And 3,500 of these were GIM admissions. They were treated by about 800 physicians. And then 11 of these were at teaching hospitals, 18 were at non-teaching hospitals, so like about 1/3, 2/3. And the typical patient was a 29-year-old, just as likely to be a male or female. And that's pretty young. Like I think 80% of patients were less than 40. So these are pretty young patients who are ending up in hospital. They were typically admitted for pain, spending about 4 days on a general medical ward. I'll tell you from the other talk, I was looking these numbers up just before this talk. 10% of these patients have documented iron deficiency, which is kind of crazy because everybody talks about iron overload. And in fact, these patients get under-recognized for iron deficiency because everyone's like, oh, well, you have sickle, so you have anemia, so nobody even checks. Or if they check, they're scared to give iron. But in fact, iron deficiency is not uncommon in this population. And I'll tell you that, I think I wrote this down, but 1% of these patients actually end up passing away as a result of their admission, which in a population under 40 is like kind of shocking that 1% of patients will not make it out of the hospital. So pretty significant, substantial burden of care. And our denominator was about 2 million general patients, out of which we got 4,000. Then we did this math thing, which basically we looked at, traditionally people have looked at, you get a transfusion, what was the hemoglobin that you were transfused at? We developed a new method because these data allowed us to do that, where we looked at this plot. So this I want to explain to you. The plot on the right basically says this is your hemoglobin on the x-axis. So how low does the hemoglobin go slowly from like 10 to 100 to 50? And then this y-axis is probability of getting transfused. So like your physician sees like 7, and you can see like this big kink, like everybody like hits go at 7. So this is for the whole population of patients in Gemini. This is threshold-based transfusion, right? Somebody's looking at a number and boom, like there's no way that everybody at 70 magically needs a transfusion, but these are the thresholds we use in practice. And this is like what we should not see for sickle cell, just so. So we published the methodology. It was well received in conferences and so on. And then we also looked at as comparisons, like what happens with other conditions. So you'll see iron deficiency and GI bleeding like have this automatic transfusion behavior, and that's okay because there are clinical trials supporting this. There's no clinical trials of thresholds in sickle cell disease. But this is what threshold transfusion looks like. At 70, everybody more or less gets transfused. Sickle cell disease looks like this. So just to orient you to the graph, it's the same type of plot. It's a little more jagged because the sample sizes are smaller. But the blue line here is teaching hospitals, and the red line is non-teaching hospitals. So the red line has the same kink. It has this like reflexive transfusion. The blue line is kind of flat, more or less, and it's just like a slow rising flat. And this is important because the blue line is how you're supposed to be transfusing these patients. Like you're supposed to like really think about each one. And so basically nothing happens at 70 because nothing should happen. Like it's not like a patient with a hemoglobin of 68 is much different than 72. In fact, that's the error range of that lab. So it doesn't really make sense to do that. So that's what we found. It's about a 30% difference. You're about 2.5 times more likely to get transfused at a non-teaching hospital compared to teaching hospital. And this is like a very significant result. Things that did not explain this result. So you could say, is it possible that patients at teaching hospitals are sicker? Somehow they can't get transfused as often. That's not true. We controlled for a lot of covariates, Charlson, but also some lab-specific markers. We looked to see if, as a hospital, maybe teaching hospitals are seeing a lot more sickle patients. So maybe they're just used to dealing with them. And what we found was that that didn't matter. So like non-teaching hospitals that saw just as many sickle patients had the same sort of reflexive transfusion practice. So it really is something about the hospitals themselves that seems to be driving this. And we looked at exchange transfusion and massive hemorrhage because we know exchanges and massive hemorrhage, they're not using thresholds to transfuse. That didn't make a difference either. So what I think could explain the results, I think a big part of it is hospital customs and norms. So if you're at a hospital where like you don't really think of sickle patients separately when somebody walks in, you don't really have the awareness, you don't have the guideline translation or implementation, you might do that. Some hospitals, like a lot of teaching hospitals, you can't transfuse without calling a hematologist. That's not really the case at non-teaching. So that filter is removed. The presence of a transfusion medicine specialist or somebody screening these things or through order sets, implementing it, and maybe just less guideline translation. So there are lots of possible reasons. We don't really know for certain, but we are looking at that. So for the next steps for us, we've contacted some folks from the Ministry of Health. We did give some presentations on the fact that there's this big disparity in transfusion, and we don't know what's going on. And really, I see this transfusion thing as like a canary in the coal mine. Like this is what we can measure with data, but I'm sure if you looked at pain management or if you looked at some other like respiratory disease management, probably this type of disparity exists across all of those things. Because if they're not reading the transfusion guidelines for sickle, they're not reading all the other ones either. So I suspect this disparity is like a marker for something much bigger. And I'm sure patients will tell you that, and patients did tell me that. Hospital level knowledge translation, so you'll see a poster from North Carolina General, which is like using the results of this study to now create order sets to flag to make sure that when sickle patients come in that they're not treated like any other patient for the purposes of transfusion, that it can be really harmful for these patients. And there's a grant coming up in fall 2026. We're actually going to, as a part of the CHR grant, we want to go to the hospitals, actually interview physicians, like sit down with emerge physicians, ICU physicians, general medicine, and say like, what's going on? Like, what are you kind of, like what is driving this practice? Not to confront them, but just to like try to understand like, what is the gap here? And how could we potentially fix the gap? We'll also audit transfusion policies at hospitals to see if they have transfusion policies and what do they say about patients with sickle. So we are going to just do a much deeper, larger data analysis. And this is because CHR actually put out a call for acute care and sickle. They're making this a priority. So maybe some people in the room are responsible for that, but that's really awesome. So we want to leverage that opportunity if we can. So with that, I'll finish by thanking the Gemini team. I will just say, put a plug that by doing this work, we also have now like curated, cleaned up this database for research. So if anybody has ideas, and not a huge amount of money is needed to explore your ideas related to anything for sickle care across, Gemini now has 39 hospitals since we did this analysis. So that's a big data set to interrogate questions you might be interested in. We looked at transfusion, you can look at medications, you can look at processes of care. So there's a lot possible with this data set. And I think we've also prepared it for more researchers to come in and look at other questions. So I hope that's interesting, and I'm happy to take questions.
Thank you so much for the wonderful talk. We're going to save the questions and answers for the very end. So in just a moment, we're going to have Dr. Mack with his presentation. Just check it works. Okay.
All right, can you hear me okay? Yes, all right, fantastic. So thanks a lot. I do want to thank SCAGO for inviting me to talk today. It's really a great pleasure to participate in the day. I think these kind of conferences that combine multiple different disciplines, patient perspectives are really so valuable. So I really appreciate being here and being able to talk about something that I think is really underused, underutilized, and hopefully something you can kind of walk away with from here and go to your hospital and say, hey, we should be doing this more often. So unlike the program, I changed my title last minute, and something a bit more catchy, unfortunately, didn't make it into the program, but it's doing more with less. Isovolemic hemodilution red cell exchange. So this is the promised apheresis talk. In terms of disclosures, like Raza, I work at CBS, so I'm a medical officer at CBS. What I'll be discussing today doesn't really have anything to do with my CBS role and doesn't reflect the views of CBS either. They're kind of my own personal views as a physician hematologist. And what we're going to talk about today, so the outline, I'm going to go through a description of automated red cell exchange, what the procedure is. For those of you who already know, I'm sorry, I just want to make sure we have some level setting and that everyone's at the same starting point. Talk about some of the indications for red cell exchange in sickle cell disease, and then go through an introduction to isovolemic hemodilution red cell exchange, which is a mouthful, and how it can optimize red cell utilization in this patient population. So to start with, what is a red cell exchange? I don't know, show of hands, who here knows what a red cell exchange is already? Okay, good. Less than half the room. So it's a procedure used to replace patient red blood cells for donor red blood cells. This was alluded to this morning by Dr. Clausen, Dr. Johnson, as one of the methods of delivering transfusion therapy for patients. So it's done to reduce the hemoglobin S concentration. That's kind of the ultimate goal of an exchange transfusion. And there's two ways that it can be done. So there's a manual way of doing it, which is the original way it was done, where you actually physically remove blood from somebody, by just letting it drain out into a bag, a phlebotomy, and then retransfusing. That's a manual exchange, quite time-consuming, cumbersome, fairly inefficient. And then the automated exchange, which is done with a machine. It's a computer that kind of programs it, and it's much more efficient, so sort of like driving a car. Although unlike driving a car, it's a lot more fun, I guess, to do the automated compared to the manual. The one different there. I'm not going to talk at all about manual exchange today, so I just want to make sure the differences were clear, but everything I'm talking about today is about automated exchanges. So what is an automated exchange? So we have here a patient who's come in. Do I have a laser pointer? I do not. So the patient's here sitting in the chair. They're hooked up to the apheresis machine, and the steps that are going to happen is, one, the blood is going to be taken from the patient to go into the machine. In the middle here is a centrifuge. That's the circle in the machine. And that centrifuge is going to be spinning really, really fast to be able to separate the red cells from the rest of the blood, the plasma and other cells. And then the machine is going to divert up the red cells into a collection bag. And then the rest of the red cells are going to be diverted from a donor back into the patient, along with their separated plasma and all their other cells. So by the end of the procedure, what you've done is you've got a collection bag filled with their original starting cells, which for someone who's never had a procedure before, those are going to be all sickle cells. And then they'll be transfused healthy donor cells that don't have the sickle mutation. So you've effectively reduced their hemoglobin S concentration. So that's an automated red cell exchange. I like some of the history of medicine quite a bit. So when you go back in the literature, IBM, which was preceding the days of Dell, was a computer, the computer manufacturer. They actually had the first automated red cell exchange machine. It was designed by an engineer for collecting stem cells from his son, who I think was affected with leukemia. And then someone really smart said, hey, we can actually use this to separate all types of cells. And this was the results from the first patient that actually had an automated red cell exchange done. So you can kind of get an idea of what's happening in a patient when we measure their hemoglobin, hemoglobin A, hemoglobin S, if you follow these trends here. So what they've done here is, on the left-hand side of the curve is how much blood they had processed. You can see that the hemoglobin goes up as the exchange went on, at least the way that they did this exchange, they increased the hemoglobin. That doesn't have to happen with the red cell exchange. And on the bottom curve here is kind of the important changes you see is that the hemoglobin S, which is shown in this line here, drops with a pretty steep drop and then sort of tapers off. And the hemoglobin A level kind of follows the inverse, where it's going to go up and then sort of taper off as the exchange goes on. So a really nice way of reducing the hemoglobin S, increasing hemoglobin A, and then that's going to translate into clinical benefits, less sickling, vaso-occlusive crises, complications from sickling over time. So that's kind of the whole principle of it. These are the new machines, or the modern machine that we use. So it can be done on any machines. At our center, we use the Spectra Optia. So this is kind of when the Spectra Optia is taken apart, what it looks like on the inside. The big center drum there is the centrifuge, which is spinning really, really fast. It works just like a washing machine, basically, so when you put in your clothes, there's a spin cycle, the water gets sprayed out and the clothes stay in the middle. It's just the opposite happening with the red cells being sprayed out to the outside, and they're gonna get diverted out in a separation channel. So this is what the components look like on the inside. Close-up view of the centrifuge. This is the separation channel in the middle, so it's just a small PVC belt that's gonna fill up with the patient's blood, and that's what's gonna be spinning around really fast inside that drum. These kits are really important because it means that the machine can be used over and over and over again without having patient's blood touching other patient's blood, so it's just reusable and sterile. And this is really kind of where all the magic is happening. This is the separation chamber, so it's pretty unimpressive, but at a very, very kind of small level here, you can see at the bottom there's kind of a channel with this clear tube that's at the very far end. That's where all the red cells are going to kind of be pushed out and eventually then re-diverted up into collection bag. And then the plasma is going to go through this yellow line. The line is actually colored yellow, so there's no plasma in there right now, but that yellow line is going to return that to the patient, and then they'll get the transfusion of red cells as this is going on. So that's kind of how it's happening as it's running on. This is how it looks like when it's kind of set up. So this is the tubing cassette. There's a whole bunch of complicated pumps and an air filter. And then this is the separation chamber that I showed on the previous slide, but now it's actually filled up with a patient's blood. And so you can see here that far line here is now red blood cells that are being concentrated, and they're being diverted off to a collection bag. And that nice golden yellow plasma, that's the patient's plasma that's going to be diverted off down a separate tube and re-given back to the patient. So that's kind of how it works. I have a very underwhelming video, which, do you mind starting the video, or is it going to play? It may not play. If it doesn't play, you're not missing anything. See if you click, if I click. Nothing happens. Don't worry, you're not missing anything. The whole point actually was that it's kind of underwhelming, because I think when patients go in and they think about exchanges, it's a pretty anxiety. Oh, there we go. So it's moving. See, it's like pretty, I told you it was unimpressive, right? The pumps are turning. It's really silent. There's kind of like a low hum, really easy to fall asleep to, but pretty kind of not all that scary, even though for a lot of patients going in, it's a pretty anxiety-inducing time because it seems like a pretty heavy-duty procedure. And it really is when you think about what's actually going on. But the actual experience of it is, for the most part, pretty unexciting. That was just a backup photo, I think, in case the movie didn't work. So that's red cell exchange. What are the indications for red cell exchange? So we've got kind of two different buckets of exchange categories. There's the acute, things that you might want to do an exchange for right away, and then there's the chronic. So in terms of the acute indications, an acute stroke. So anyone's had an acute stroke, an urgent red cell exchange is indicated. Severe chest crisis, so requiring oxygen, not improving with oxygen therapy, requiring mechanical intubation or mechanical ventilation. Unresolving pain crises, so a pain crisis that comes in, maybe you've tried simple transfusions, that's not working, the pain crisis is still going on, an exchange transfusion might be indicated there. Multi-organ failure, and related to that, the sickle hepatopathy or intrahepatic cholestasis, so a severe liver sickling crisis. And then finally, preoperative optimization. So there's some pretty good data that in patients who are going to be going for surgery, some form of transfusion therapy is needed, and if there's not enough space to give them a simple transfusion, spaced by their hematocrit, you don't want to transfuse too high, then you can use an exchange transfusion to get their hemoglobin S concentration down in preparation for surgery. On the chronic side, we have primary stroke prevention, secondary stroke prevention. So someone who hasn't yet had a stroke, but whose transcranial Dopplers might show high velocities, we know that person's high risk of having a stroke, so we want to use exchange or some form of transfusion therapy, and exchange is probably the best way of doing it on a long-term basis. Or secondary stroke prevention, someone who's already had a stroke. It's not just at the time of their stroke, but we want to actually maintain their hemoglobin S low moving forward. So we would use exchange for that kind of a patient. And then for someone who's had recurrent pain crises that aren't really doing well with hydrea, then it's kind of that option. Dr. Clausen went through this morning, is kind of that next tier of therapy available for those patients. So those are kind of the indications for RBC exchange. What are the pros and cons when we think about RBC exchange, automated versus maybe a manual exchange, or even just simple transfusions for controlling hemoglobin S? So the pros is that it's neutral from a point of view of hematocrit and viscosity. So if we do an RBC exchange, we're keeping everything level, everything even. The hematocrit doesn't have to go up. It can stay even with whatever you started with. So if you come in with a hematocrit of 28%, you can leave with a hematocrit of 28%. We're not adding any more blood to the system. And from a viscosity point of view, because the hematocrit is staying the same, we're not changing your blood viscosity either. Whereas if you do a simple transfusion, one of the walls you're going to hit as a clinician is you can only give so much blood before the hematocrit is going to go up and the viscosity is going to go up. And for the patient whose viscosity starts to go up, now those transfusions are actually going to be detrimental rather than helpful because they're not going to have as good blood flow, they're not going to have as good oxygen delivery, and that's going to cause problems from a sickling point of view. So we avoid that problem with RBC exchanges. It's iron neutral. So Dr. Johnson mentioned problems with iron this morning, and I wanted to put my hand up and say, yeah, make sure we emphasize the RBC exchange, so he did that, which was great. Because these exchanges are iron neutral, and if anything, patients might actually lose a bit of iron over time with the exchanges because there's small amounts of blood loss that happen with the tubing and everything else. So if anything, we see iron deficiency developing in our exchange population, but they're really iron neutral. So as opposed to someone who's getting regular exchanges and they're just accumulating that iron, every single transfusion is 250 milligrams of iron, it just goes up and up and up. With the exchange, because we're removing and then giving back the transfusions, it stays balanced. So that's another benefit. And then it's volume neutral, so we're not adding anything to the system. This kind of links up with the hematocrit idea, but we're not giving, if you give someone a simple transfusion, it's about 300 mils per bag of blood. So if you give 4 bags of blood, that's 1.2 liters of volume you've given. Someone has to be able to tolerate that from a heart point of view. We know patients with sickle cell disease can have heart issues, pulmonary hypertension, so adding a bunch of volume to the system is not good. This avoids that problem by just keeping everything even. So that's the other benefit with it. What are the cons? So it does require specialized nursing and equipment, so we have to be close to an apheresis center. Not everyone lives somewhere close to an apheresis center, and even if you're in like the Greater Toronto area, you might live somewhere that takes you an hour and a half to get to the hospital where they have an RBC exchange machine, so it's not ideal. It often requires a special catheter, so not always, but a lot of the time you need a special catheter. We can't just do this through a regular IV for most patients because the IVs can be difficult to get. Although if you have good veins and you can put an IV in, we can do that. But oftentimes there's challenges getting the veins. The veins aren't cooperative, so we need to put in either a special central line that gets put in and removed every single time the exchange is done, or patients will have what's called a port placed under the skin, which has its own set of complications, so a bit of a downside. There's a risk of citrate reaction, so we can't take someone's blood out and have it go through this machine and expect it just to sort of be happy doing that. It wants to clot when you're doing that, so we have to mix the blood with something called citrate to prevent it from clotting. And that citrate can cause people to have low calcium levels, which can cause some challenges. And finally, it requires way more blood than a simple manual transfusion would. Although I put an asterisk next to this one because when you compare the efficacy, how good are we at reducing the hemoglobin S with a simple transfusion compared to an exchange, they're really not apples and apples or oranges to oranges. They're much, much different therapies. So if you were to compare the two, it's more efficient with an exchange, but it does require a lot more blood. Okay. This is, the next slide here is just a picture of some blood I took from, or a picture of blood that was going to be used for an exchange for one of our patients. Just a regular size, I think 22-year-old male, and it's about 14 units of RBCs. So you can imagine that's a lot of blood to be giving. For a patient who might have a rare blood type, which in the sickle cell population, that's not uncommon to have a rare blood type, you're asking your blood provider to be giving you 14, 15 units every month of a rare blood type. That can get quite taxing. And often, because of the ethnic associations with the rare blood types and with sickle cell disease, you're having to ask the same pool of donors for their blood that's matched pretty well, which means you're all competing kind of for that same small number of donors. So that can get kind of challenging from a blood point of view. Why does this happen, or why do we need so much? And what's another problem with the exchanges is this idea of diminishing returns. So if you look at this curve on the right-hand side of the screen, or your left, this is the relationship between how much blood we treat with an exchange or with the apheresis machine and how low we're going to get the hemoglobin S concentration. So on the vertical axis is the hemoglobin S concentration if you have someone who's assuming starting at 100% hemoglobin S. As we treat around, just jump off the stage here, but right here is like 1 blood volume. You're going to get their hemoglobin S down to around 35%. And you can see that the curve then starts to flatten out. So the more volume you treat, the more blood you actually have to use to be able to get smaller and smaller reductions in hemoglobin S. That's the diminishing returns part. And when you look at it here, I just kind of summarize, here's, if we're aiming for, say, 30% hemoglobin S from someone, it would take us about 2,366 mils of RBCs to achieve that level, which is 7 units of blood total. If we want to get that same patient down to 20%, so just a 10% reduction, we're going to have to give another 4 units of blood, so almost double the amount of blood to get just a 10% reduction of hemoglobin S. So it's really kind of inefficient, and that's because as the patient is on the machine, we're actually recirculating the patient's blood, right? So it's not like we're only taking out the sickle cells. We're actually taking out donor cells as the procedure is going on. And the longer the procedure is going on, the more and more donor cells you have, so more and more donor cells are getting put in the bag, which is why you get that curve that kind of does that sloping reduction, right? So that's a bit of a problem. So is there a better way? Well, what if I told you that there's a slight modification of the standard automated RBC exchange that we can do that gives you the same end results, but uses a lower volume of red blood cells? Well, some of you might say, you sound like a snake oil salesman. I'd say, fair enough, fair enough. But there is, and this is this isovolemic hemodilution red cell exchange. So what this does is it takes advantage of kind of the relative aspect of the reduction in hemoglobin S. So here on the top, I'm just looking at a standard red cell exchange. If you imagine this is the patient's blood before and after the exchange, you've got 100% hemoglobin A and then or 100% hemoglobin S, and you shift it over, and you're going to be about 30% hemoglobin S now, so it's diluted to a purple color. Okay, what do we do if we do an isovolemic hemodilution red cell exchange? Well, we take that patient who's starting off, we reduce their hemoglobin completely. So we actually just pull out blood from them without replacing it with red cells. That's the depletion part. And we replace it with either saline or albumin. That's the isovolemic part. The volume stays the same. So we're not making them low volume, we're just reducing their hematocrit. Then we go ahead and do the same exchange that we would have done. So now we exchange it over, and then we transfuse them back up to whatever starting hematocrit they were. So even though we end at the same point, because we do this reduction, since 70% of A is going to be less than 70% of B because B is a smaller number, we don't have to use as much blood to get the same hemoglobin S concentration at the end. Right? Great. So if you want to kind of look at numbers, this is like if you run through kind of the calculations of what blood volume you need to do an exchange on a woman, this kind of a person, 160 centimeter woman, 70 kilograms with a pre-hematocrit of 28%, and we're aiming for an end hematocrit that's the same 28% with an FCR, so a fraction of cells remaining. That means we're lowering hemoglobin S to 30%. What would we need? So for a standard red cell exchange, it would be 2,366 mils, which is approximately 8 units of RBCs. If we're looking at like sort of 280 to 300 mils per RBC. If we do an isovolemic hemodilution red cell exchange, we only need 2,022 mils. That's about 7 units of RBC. So we saved 1 unit of blood, right? One exchange, not a big deal, right? But a lot of these patients who are getting these, they're having them done every 4 weeks, every 6 weeks. So on a year, that's 10 to 12 units of blood less. And that 10 to 12 units of blood, if it's a rare blood type, that's 1 extra patient we could treat, right, with that 1 extra exchange we could perform. So, and you multiply it over the number of patients that is being done, and it starts to become kind of meaningful differences. So that's kind of how the numbers are. In Ottawa, when I was there, we rolled this out as a quality improvement project, and we looked to see, okay, well, does that actually play out in real life? And what you can see here, just highlighted, is so we did sort of a pre-post comparison of when we introduced these red cell depletions for all the patients that we thought would be eligible for it. And you can see here the number of red cell units that we used per patient went from 8.8 to 7.9 on average per patient. So we used like pretty much 1 unit less per patient per exchange. The pre-hemoglobin S stayed pretty much the same, and importantly, the last line there on the table, their hemoglobin S at the end of the exchange didn't change. It was 10.9 versus 10.1. So we're doing the same efficacy, but using less blood. Seems like a win-win for everybody. We didn't notice any increase in reactions or any kind of side effects from it. It was really well tolerated. And when we looked at the whole program altogether, and this is just 22 patients over a 6-month period, it was 107 units of blood less that we used as a program. So I think like a big win for the system in general. That freed up blood for other patients to get. Pros and cons of it. So I'm not going to be a snake oil salesman and tell you like this is just like there's no risk to it at all, because it does come at a bit of a cost. The pros, just to go through those, is the same end results as I've already harped on. It's a lower red cell requirement, which, as I said before, is particularly relevant for patients that require a rare blood type. Not just because you might use less blood for that patient, but if you have only a limited number of red cells that you can actually use for that patient, you can optimize. You can actually get a higher or a lower hemoglobin S at the end using the same amount of blood. So that's kind of the other way of looking at it. What are the cons? Well, it's a temporary worsening of anemia. So you do make someone more anemic when you're doing the red cell exchange. If you don't make them anemic enough, you're not really going to save much blood. So that's a bit of a problem. People have to be able to tolerate that temporary anemia. And then the donor unit exposure is really only going to be lower if you have the appropriate pre-hematocrit and blood volume. So if you try and do this on a small patient, you're not really going to save much, right? Because that delta between what you started with and what you did when you lowered it, it's going to be so small, you're not going to save a full unit of blood. And because we either transfuse a full unit or don't transfuse a full unit, like we're not going to give half a unit and say, oh, that was a win, because that unit can't be used for anybody else once it's been spiked. So we kind of have to save at least 1 unit of blood to make it worthwhile. So those are kind of the cons. Just in terms of reactions and tolerability, and I think running a little bit over time, I'll finish up really quick. There have been a couple studies that looked at the safety and tolerability of these exchanges. An American study that was done in Texas and one in France. The one in the US, they did find an increase in mild vasovagal reactions, so patients that experience a little bit of dizziness or lightheadedness during the exchange or shortly after the exchange, or a little bit of an increase in blood pressure that might have been completely asymptomatic, sorry, a decrease in blood pressure that might have been a bit asymptomatic, or an increase in heart rate that again might have been asymptomatic. So there was a 23% of patients in their study compared with 7% that didn't have the depletion done. So there was a signal that they had, maybe a little bit more of those kind of mild vasovagal type reactions. In the French study, they found no difference at all. And one key difference between the two studies is that the American study used just saline as replacement. So when they lowered the hematocrit, what they used to replace that volume was just normal saline, whereas in the French study, they used albumin. And the difference between the two is that the albumin it pulls water into the blood vessels, whereas saline tends to just leak out over time. So I don't think every patient needs to have the albumin replacement, but if you are a program that isn't doing this, you want to do it, but you're worried a little bit about the hypotension or some of the tachycardia, things like that might go on to the patient. I think reasonable to start off with saline replacement, and if patients are having a struggle with it, don't give up. Try albumin as a replacement for your volume, and that might actually solve the problem. And that was what we did in Ottawa, and it worked pretty well. So just to show you kind of the concrete savings we have here, or how the pre-hematocrit impacts things and why that may not result in a savings of blood in the unselected patient. If we take that same woman we were talking about earlier with a hematocrit of 28%, and we make her hematocrit 23%, so that's all I've changed here, everything else is staying the same. If we do our standard red cell exchange, it'll take 2,149 mils of RBCs, so about 7 units of RBCs now. And with the isovolemic hemodilution red cell exchange, it's lower, but it's 2,022 mils. It's still going to take about 7 units RBCs. So we're not really doing her any favors by doing an isovolemic hemodilution. We're just making her more anemic temporarily, maybe giving her a higher risk of tachycardia, hypotension, et cetera, but not really saving much in terms of red blood cells. So we got to kind of like tailor it according to the patient. And that's exactly what we did in our Ottawa program. And what I think should be done if this is done in other centers is you got to go through patient by patient and figure out, okay, what's the delta that I have to do for hematocrit? If their starting hematocrit is this, what's the lowest I have to make their hematocrit to actually save a unit of blood? And that's how we order it for our nurses. We say, if their pre-hematocrit is this amount, do a red cell exchange. If it's not that amount, or if it's lower than that amount, just do a standard red cell exchange. And we find that kind of works pretty well. So it's not suitable for all patients. Which patients should this not be done in? Well, anyone who couldn't tolerate a temporary reduction in their hematocrit. Thankfully, most patients can, and because you're just sitting in a chair and you're not doing anything, you don't really need all that high hemoglobin. We have way more blood. Even when we're anemic, we still have way more blood than we actually need, which is why like Dr. Raza's talk there about transfusing at like a very low threshold is okay, because you don't really need as much blood as we actually have, unless you're active and doing things. But when you're sitting in a chair, not a big deal. But so who would we not want to do this for? I think patients who've had a recent stroke or a recent myocardial infarction, not a great idea. After time, once they've had time to recover, probably 6 months or so, I think reasonable to try it. Anyone who's got like an arterial blockage or an arterial narrowing, so someone who might have angina, they go walking, they get angina pain, probably not a good idea to like lower the hematocrit. You're just going to bring on angina pain for them. Anyone with moderate or severe pulmonary hypertension, probably best to stay away from. Anyone with organ failure, acute illness, those patients who are in with like acute chest syndrome, that's not the time to be doing a depletion exchange. And anyone who's previously not well tolerated the depletion probably should just stop and do a standard red cell exchange. So where does it fit in this treatment? I'll tell you my perspective is I think actually this should be the standard for when we start off patients on red cell exchange, whether it's a pre-op exchange that's just going to be done once, or it's someone who's on chronic exchanges. Aside from those conditions where we might be worried about the lowering in hemoglobin or hematocrit, I think that every patient should start with an isovolemic hemodilution, and then if we see there's poor tolerability, then shift back over to RBC exchanges, because we're exposing them to more blood, exposing more risk of transfusion reactions, and using up a valuable resource for the patients with rare blood types when we don't have to be. But that's my perspective. So to close, and just in summary, RBC exchange is a method of transfusion therapy with the advantage over simple transfusion of being iron and viscosity neutral. The isovolemic hemodilution red cell exchange improves upon the standard RBC exchange, offering reduced RBC exposure in the appropriately selected patients. And patients with anemia-sensitive conditions should not have that procedure done. And I'll stop there and open up for questions, I guess. Thanks.
A round of applause for our two wonderful speakers. I'd now like to open up the floor for any questions. Questions? All right.
Excellent talk. Thank you very much. I know this is about red cell exchange, but I have a question on plasma exchange for those patients who may be in severe multi-organ failure, but they can't be transfused. I'm thinking of things like hyperhemolysis, or they don't accept blood products. Is there any role for plasma exchange?
So for which patient group? For
Adults.
hyperhemolysis.
Yeah.
There's not a lot of great evidence for any of those patients that plasma exchange does any benefit, as far as I know, because it doesn't. So the mechanism of hyperhemolysis, where you have an antibody that destroys some of the blood and then starts destroying the patient's own blood cells.
Yeah.
That's kind of the mechanism we think. The amount of clearance that you're going to get on that antibody with plasma exchange is going to be like pretty minimal. Like it'll be like if you start off with, you do an exchange, it'll go to 30% of whatever your starting level was, and a lot of time those antibody titers are going to be much higher than you're going to get a reduction in, so you'll still have clinical hemolysis there. So I'm not aware of any evidence that plasma exchange is beneficial for hyperhemolysis specifically. The one condition that can develop in sickle cell disease that plasma exchange can be helpful for is fat embolism syndrome. So that it's a really rare complication, but in some patients who have a severe vaso-occlusive crisis, you can get fat that escapes out of the marrow into the circulation, and that can cause this really severe hematologic and neurologic condition where people can be comatose with signs of platelet destruction and other really bad stuff going on in their blood. And plasma exchange can help with that situation, but I'm not aware of too many other indications for plasma exchange for sickle cell specifically.
Okay. One last question. I know you mostly covered the automated exchange. I have a question about the manual exchange. I think ASH guidelines suggests maybe in severe cases of acute chest syndrome and you don't have immediate access to automated exchange, you could do manual. That's what ASH guidelines have suggested. But in actual clinical practice, would you be comfortable to do this in a very acute setting where the patient is very unwell? Would there be a place for that? I don't know.
Yeah, I think so. You have to look at each setting individually. I think it's hard to make kind of broad brush remarks. But in the appropriate patient where you may have delays to care, I think absolutely I would feel comfortable doing a manual exchange in that kind of a patient. So I've had patients who were transferred to us for red cell exchange where we had no nursing availability overnight, and it was someone who had a stroke, and so we started a manual exchange that night. I actually think manual exchanges are underutilized in general, that when we think of exchange, we automatically think automated exchange, and we don't use manual exchanges enough. So I'd say in general, yes, I think that kind of patient who you're going to have delays to a red cell exchange, it can be quite helpful and life-saving in some situations. Like getting that hemoglobin S level down as quickly as possible can reverse some of that pulmonary injury or prevent it from progressing really quickly. And I wouldn't have too many situations where I'd be concerned about using a manual exchange because the amount of blood loss is pretty small with it. Like to phlebotomize 500 mils, replace it right away, and then another 500 mils and replace it with transfusions. So it's a fairly low period of time that they're actually losing some blood volume.
So in that case, would you do a simple transfusion first before attempting the phlebotomy?
No, you usually do the phlebotomy first. So you would do, the acronym I was always taught was bleed, bolus, bleed, transfuse. So you phlebotomize your 500 mils and then
that's the part I worry about.
Yeah. Yeah, so again, and I don't want to be overly overgeneralized because I do think you have to be mindful and cautious and not, it may not be appropriate for every single patient, but that 500 mil blood loss, for most patients, it's going to be completely tolerable, and you're replacing it fairly quickly with volume. So I don't think for most patients, it would be uncommon that I'd be super concerned about the tolerability of a manual exchange, especially if I'm dealing with an acute chest syndrome that's really severe and I'm anticipating a long delay to getting a definitive automated exchange. I think the importance of getting that hemoglobin S level down is really important. The one final thing I'd say about it is just in the cases I've seen in reality, the hemoglobin tends to be so low that you would just do a simple transfusion. You have a lot of space to sort of push the hematocrit up before you start worrying about getting into hyperviscosity. So it's fairly narrow, the number of cases I've seen where I think where a manual exchange really would be appropriate, and that you wouldn't just do a simple transfusion.
Thank you. Thanks.
Thank you so much for the presentation. My question is, with the so many packed RBCs given to the client with the exchange, is there a risk for alloimmunization? And the second is, with normal or iron deficiency anemia with sickle cell clients, would you recommend replacement, cautious replacement of their iron?
Yeah, super. So yes, there is a risk of alloimmunization, and that's where I think the isovolemic hemodilution is an important intervention, because you're just reducing the number of donors that you're exposed to. For these patients, we are doing extended matching, which is going to help to mitigate the alloimmunization risk. But there is that ongoing risk of alloimmunization anytime you get a transfusion, which is why transfusing, not based on a strict threshold, but more based on patient features and clinical features, is so important. For heading for transplant?
If they're considered, or for consideration in the future for transplant, would it be like a stop thing, or would you still?
No, in fact, pre-transplant, like the gene therapy, especially, actually, the protocols require the red cell exchanges, because you want to make sure. I mean, some of the arguments for that is that the bone marrow environment gets improved with lowering the hemoglobin S, and so your chance of getting your stem cell collection is going to be, your yield is going to be higher through reducing the hemoglobin S, and then it also improves the conditions around the time of the conditioning. So whether you're doing a gene cell therapy or a stem cell therapy, that conditioning period is quite toxic. You're giving all these medications that are quite toxic, so you want to make sure the hemoglobin S level is low. So it actually is a reason to do the exchanges. So I wouldn't view it as a barrier or a reason not to proceed with transfusions. On the iron question, I struggle with this one a lot. I don't know what the right answer is. I don't know. Be curious to see what other hematologists do, but because the iron deficiency is a little bit of a double-edged sword. On the one hand, it probably helps to reduce production of hemoglobin S. You're going to maintain a better hemoglobin S level if you are iron deficient. You're not going to replete, or you're not going to rebuild your blood as quickly. So it can help to slow down the hemoglobin S curve. But then at the same time, people can have sort of non-hemoglobin related symptoms. Myoglobin probably has some iron in it, and so there's kind of this balance. So I tend to kind of go by patient symptoms. If someone is feeling really well, despite being iron deficient, we'll just monitor. We won't replace it. But if I had one patient who was like eating drywall, and so we're like, we can't have that. We're gonna have to replace your iron. So it kind of depends case by case, I think. The drywall was because of the pica symptoms, just to, yeah. Exactly.
I'm glad you clarified that. I was scared for a second there. I'm Sarah from Hamilton. Do you use hydroxyurea in combination with your apheresis exchanges to try to boost the efficacy by helping to promote fetal hemoglobin and the replacement hemoglobin that your folks make themselves?
Yeah, so we don't do it as a matter of routine, but we will add it on, or suggest that it gets added on, if a patient is having coming in with poorly controlled hemoglobin S despite sort of relatively optimized apheresis parameters, or in patients who may be having kind of pain crises, et cetera, despite the exchanges. So we'll kind of add it on as an adjunctive therapy, but we don't do it as a matter of routine. Yeah.
I'm going to ask the question to Dr. Raza. So what are some potential reasons? I think you mentioned that there's some inter-hospital disparity between the teaching and non-teaching hospitals. Could you maybe explain what might be some of the underlying reasons for this observation?
I think the main one probably is that people don't know how to treat sickle cell disease. Like, that sounds really blunt, but I think it's, especially if you're at a smaller hospital and you don't see a lot of these patients, you don't get a lot of education, your department doesn't focus on it, you just may be unaware. I think if physicians knew how to treat these patients, they probably would treat them the way they should be. I think it's a lack of familiarity, but I don't think it's just exposure. Like, I don't think it's just the number of patients you see. I think it has to do culturally with, like, do you have somebody who's championing this at your hospital? Do you have concentration of patients? Often these patients are also a bit marginalized in some areas, so can they advocate for themselves to get the right care too? And in the other session, one of the patient speakers was talking about, like, speaking back to your physician and, like, letting them know that this is my care, like, I'm sort of an expert in my own condition. I've lived with it my whole life. So I think also empowering patients while we get these system level changes is a really good way to get at that. But I think a lot of it is lack of knowledge.
Okay, thank you very much.
Yeah.
Any other questions? I have another curiosity question for Dr. Mack. So my understanding is that the apheresis or red cell exchange typically takes about 4 hours for the patients, and they spend basically a whole day there. For the saline or albumin replacement, how long might that take, or does that make any difference to the day?
It's actually, I should put up there, it's pretty well time neutral from an exchange point of view. The exchanges take, it depends on the blood volume that's being treated, so it depends on the patient size, but anywhere between 2.5 to 4 hours for an exchange. And that doesn't include the burden of the patients having to come in, have their type and screen done, a few days before the exchange, then come in, have the exchange done, and sometimes there's delays waiting for blood to come, et cetera. So it is quite demanding on patients, and I do think it's important to acknowledge that. But the isovolemic hemodilution part doesn't actually change anything. There's about a 15 to 30 minute period at the beginning where that initial exchange is ongoing, but then because you've lowered the hematocrit, there's a lower blood volume that you're actually having to exchange, so it cuts down the time of the exchange part. So all in all, it's pretty time neutral.
I'm going to ask one more question then. So this is for Dr. Raza. You mentioned that there might be some disparities in understanding of sickle cell disease. What are some potential next steps that you see for the work that you're doing and your collaborators for implementing the type of work you're doing to improve the care for patients with sickle cell disease?
Thanks. I do a lot of guideline implementation work in hospitals because, guidelines come out and physicians, when they're transfusing, they're not constantly looking at this literature. They may not have the time or necessarily the interest to do that. And I think one of the big things that we have to advocate for in this space, the last cell therapy, gene therapy talk was talking about what do you do with these patients who are lost to follow-up after gene therapy or transplant? I think the answer is to build really robust registries, passive registries. So in Ontario, at least, we do have things like ICES, which are these province-wide registries that track all patients and healthcare utilization, even outside of your clinic. These databases can track patient care. If your patient goes to Thunder Bay for some reason and goes through an emerge, you can track that in a database like that. So instead of having to rely on manual, time-intensive, personal-like registries within your center, I think there are all of these resources. I don't think we've tapped nearly enough into what's possible. So I think we need to do a lot more with the data. And also in advocating to the province or talking to stakeholders or talking to pharmaceutical companies and showing them what a huge population we have that we can work with. I think a lot of these things require numbers because I think stories are really powerful and stories are what motivates people. But in policy circles, in power circles, often it's the data that speaks really loudly. So I would say that's where my focus is to take some of these data to funding agencies, to advocacy groups, to hospital administrations and CEOs and saying, look at how you're performing on sickle cell and can we do better? So.
All of that rings true for me. I absolutely agree. I want to ask everyone to join me in a round. Oh, I missed. Sorry.
Hi. That was both really great presentations. I definitely learned a lot. My name is Karina. I did have a question about apheresis and just alloimmunization. And because you're giving more units of red blood cells, do you notice that there's more reactions to the blood when you're giving it compared to simple transfusion?
Yeah, it's a great question. We don't tend to see actually a higher rate of reaction with the apheresis compared with simple transfusion. So thankfully, the rates of reactions in general are fairly, relatively low. I think the most common are minor allergic or low-grade fevers that are not dangerous. That happens in about 1 in 100 to 1 in 300 transfusions overall. So if you're giving 10 units of RBCs, you have 10 times the risk that you would if you were just giving a one RBC. So it's kind of higher from that point of view, but it's not a higher, per unit transfused, it's no different from a regular transfusion.
Okay, now I'm gonna do a last call. All right, please welcome, join me in a round of applause for our wonderful speakers. All right. So as we've been mentioning today, please, your feedback is incredibly important to us. There are QR codes on the back of your name tag. This is for the individual session evaluation. Following this, there is going to be a short afternoon break. And then after that, we're going to be going to the Muskoka Ballroom at 3:35 for the research abstract oral presentations. And then since I have you all in the room, we did talk a lot about blood today, and we also have Canadian Blood Services outside. They are actually trying to recruit more people, or we're trying to recruit more people to join our Partner for Life program, which is to get more donors to donate under the SCAGO PFL. Again, trying to get more awareness about the importance of blood donation for our community affected by sickle cell disease. Please, if you are able to donate or if you're interested, sign up for the PFL, learn more about blood donation, and then enter yourself into a wonderful raffle prize, potentially. That would be really, really amazing. Thank you very much.